our field is not to put you to sleep. All our training is basically to put you to sleep and bring you back to life. But that incident actually taught me that डॉक्टर भगवान नहीं होता. डॉक्टर साहब होश आ जाएगा ना पक्का. कहीं मैं बीच में तो नहीं जाग जाऊंगा. Hours and hours of boredom and moments of terror. AI is going to be a big player in this field. It is going to support an anesthetist. It is going to be a buddy for every anesthetist. मैं मुन्ना भाई MBBS में बोला था कि मैं यहाँ पर किसी के साथ इमोशनली अटैच होने नहीं आया. But end of the movie, they actually proved it. That emotional quotient is very important. People will not be replaced by AI. People without AI knowledge will be replaced by people with AI knowledge. Everything is possible. Manifest it.
Every day, thousands of people walk into an operating theater. Most of us spend weeks choosing the right surgeon. But very few of us stop to think about the doctor who stays by our side through every second of the operation. It's one of the most important roles in medicine, yet perhaps one of the least understood. And that's exactly why we're here. I am Mansimran Singh and welcome to Beyond the Surface, a podcast where we go beyond titles, beyond headlines, beyond the obvious, to explore the people, the ideas, and the systems shaping the future of healthcare. And for our very first episode, I couldn't think of a better guest. Joining me today is Dr. Gurpreet Popli, Medical Director at CK Birla Hospital, Delhi. With more than 2 decades of experience, Dr. Popli has cared for thousands of patients, worked alongside multidisciplinary surgical teams, led critical care, and contributed to building safer healthcare systems. Today, we're going to understand the world of anesthesia like never before. We'll talk about what really happens inside an operation theater, the decisions patients never see, the myths surrounding anesthesia, the future of healthcare. Thank you for joining us today, Dr. Popli. It's lovely having you here.
Thank you for having me here.
So, let's start from the beginning. What made you choose medicine as a field?
I come from a family of doctors. You know, my grandfather was a doctor. Both my parents were doctors.
Right.
So, parents always wanted, I being the eldest, they always wanted me to be a doctor. एक तो वो था which मेरे दिमाग में हमेशा रहता था कि मुझे डॉक्टर ही बनना है. एंड मैं ऑन अ लाइटर नोट, मैं जब भी हिंदी पिक्चरें देखता था ना, आप देखते थे ना, इंजेक्शन दिखाते थे, उस इंजेक्शन को डॉक्टर यूं दिखाते थे, इंजेक्शन भर रहा है, फिर इंजेक्शन लगाता है, मैंने नींद का इंजेक्शन दे दिया, अब सारी तकलीफ दूर हो जाएगी. मेरे को वो सीन इतना मेस्मराइजिंग लगता था, दैट यूज्ड टू इंस्पायर मी कि यार नहीं, मेरे को भी ये करना है, इंजेक्शन भरना है और इंजेक्शन लगाना है. प्लस हैविंग कम फ्रॉम अ डॉक्टर फैमिली, so I think that was my first choice. In fact, I never had a thought to choose anything. So I just applied for it, and I was a good student, and I got one.
So it was already in the blood.
Yeah, it was in my blood.
It's wonderful. And why anesthesia?
Why anesthesia? You'll not believe me. विद्रोह था.
Okay.
My father wanted me to become a physician, and since he being a doctor, he thought कि मेरा बेटा डॉक्टर बन के आएगा, हम नर्सिंग होम खोलेंगे. मैं अंदर से कभी किसी के अंडर काम नहीं करना चाहता था. मेरे को ये पता था, मैं अगर फिजिशियन बन के आया, अपने डैडी के साथ काम किया, तो I will be called as Dr. Popli's son, Dr. S.S. Popli's son, not as Dr. Gurpreet Singh Popli myself. Right. तो इसलिए मैंने एनेस्थीसिया लिया, क्योंकि एनेस्थीसिया was totally tangentially opposite branch, जहाँ किसी को कोई आइडिया नहीं था. I took a branch जहाँ पर I wanted to make my own identity actually. But when I took that branch, I realized it is not a simple branch. There's a lot of commitment in that branch, but I started loving it and I enjoy my branch.
Right. So anesthesia is like the doctor who's always there, but the least noticed. Is that true?
Absolutely. Right. I would say that anesthesia is like a director and a producer of the film, जिसके नाम तो एंड में आता है, पर सारा जो एक्लोड होता है वो एक एक्टर, सिंगर वो पहले ले जाते हैं. तो anesthetics is like that.
Right. So about anesthesia, are there any misconceptions that you absolutely get irritated of?
बहुत मिसकंसेप्शन है.
Okay.
सबसे बड़ा मिसकंसेप्शन लोगों के दिमाग में एनेस्थेटिस्ट जो होता है, क्या वो भी एक डॉक्टर होता है? उनको लगता है एक टेक्नीशियन होता है जो दवाई देता है, बेहोश करता है और सुला देता है, और उसके बाद जब सर्जरी खत्म होती है आता है, होश में लाता है और बाहर शिफ्ट कर देता है.
Right.
तो नाउ since the awareness is there, people actually have started realizing anesthesia is a medical branch and it takes as much number of years of hard work to become one, जो एक physician और surgeon को बनने में लगते हैं. So now that realization is there. And number two, people have started realizing the safety of patient is in hands of anesthetist while the surgery is going on. एक तो सबसे बड़ा मिथ ये है. दूसरा, लोगों के दिमाग में आता है कि मैं एनेस्थीसिया लेंगे हम तो क्या हम जाग पाएंगे या नहीं जाग पाएंगे. तो मेरे को बहुत उनको एक कन्विंस करना पड़ता है कि our field is not to put you to sleep.
Right.
All our training is basically to put you to sleep and bring you back to life. The major part is bringing you back. That is the one we are trained to. सुलाना तो बहुत आसान है. I actually tell my patients कि किसी के सिर पे हथौड़ा मार दो वो तो बेहोश हो जाता है. हथौड़े से भी बेहोश हो जाता है ना. बट क्या वो उसी स्टेट में वापस ला पाओगे उसके बाद? हम जिस स्टेट में लेके जाते हैं आपको बेहोश करते हैं, उस स्टेट में वापस भी लेके आते हैं. So that is very important.
So do you remember any defining moment in your early days when you started out, which has made you practice medicine the way you do it today?
When I was just a junior resident in before I joined anesthesia. So उस time पे I'm talking about 3 decades back. उस time पे डॉक्टर को लोग कहते थे भगवान है. वो भगवान का दर्जा देते थे. And I was working in a hospital as a junior resident. One patient tried imposing himself on me. And मेरे दिमाग में वो आया कि मैं, क्योंकि दिमाग में ये होता है ना, डॉक्टर तो भगवान होता है. And that is the first time and the last time I shouted at a patient and actually threw him out of emergency. And
Okay.
I still regret that, but that incident actually taught me that Dr. Bhagwan nahi hota. We are there to take care. It's a very noble profession and we are there to take care of people.
Of course.
And empathy is the first thing we need to learn. And this thought process actually got reinforced when in 2005 I went to UK. I worked as an observer in UK for about a couple of months. उस time पे मेरे दिमाग में this became reinforced कि the least we can do for anyone, and especially someone who is suffering, is be polite to them and give them a shoulder to cry and listen to them. I think that is the least any doctor can do for his patients. दवाइयाँ तो बाद में देनी है, इलाज तो होता रहेगा. I think the first step of being empathetic with your patient, listening to your patient, can make a lot of difference in management of that patient. That is what I believe.
So do you feel like people realize how big of a responsibility and pressure it is on the doctor? जैसे आपने बोला कि डॉक्टर को भगवान मान लिया. Right? A lot of people, I feel like, still have that conception in their heads. So, do people realize how much of a pressure that creates, and how do you deal with it?
See, I tell you, there are different type of people. There are people who will treat us as just another service provider. They are our clients, they pay us for that, and we have to deliver that service. But there are people who actually feel that yes, there is a lot of responsibility a doctor has.
Right.
People who actually give us that type of faith, they surrender themselves to us. उनके लिए automatically from within the responsibility towards that patient becomes, and it becomes a moral duty also to manage that patient, because that it is our obligation towards that person that we have to deliver the best to that person, because they have entrusted everything on us. I believe कि जो मेरे पे faith करेगा उसके लिए मैं बहुत ज़्यादा कर पाता हूँ as a doctor and as an anesthetist also. Especially as an anesthetist, because anesthesia में our patients are in a state where The only person responsible to take care of them is us. They are in the most vulnerable state. They cannot even manage their own physiological parameters, and we take care of that. So I believe if somebody has entrusted us, given his or her body to be cut in front of us in a state where they are most vulnerable, it's our moral obligation and responsibility to take care of them.
Do you remember any emotional day of your career?
Many. Well,
Oh.
I've had both sides of emotional drain. I've had a feeling like when I've done a very high risk case and I have been able to deliver my best and I've been able to bring that patient back to life and support that patient, I've felt, well, I've had that emotional, I've been overwhelmed with emotions at that time. And with the thought of gratitude, शुक्राना वाहेगुरु दा कि वाहेगुरु मेरे को इस काबिल बनाया कि मैं किसी के लिए ये कर पाया. And other side also, when I have failed to deliver, to save a life, because as a human being we can try our best, but results are not in our hand. There will be situations when, in spite of doing everything best and in spite of doing everything right for the person, we might not deliver the desirable result to that person, to that patient. And I have felt otherwise also. I've felt low, I've felt depressed because of those. I can assure you one thing, this is one profession jahan par hum, whatever we do in hospital, and if our patient is sick in hospital, well, I've had sleepless nights. I still have sleepless nights. Even after 3 decades of practice, I still have sleepless nights.
Of course. And is there any patient or one scenario that you can't forget? Some patient you can't forget.
I had a patient who got operated elsewhere, and that patient had a post-operative surgical site infection, and she was really very sick. So that patient was taken care of. She was in a different hospital. We brought her to our hospital, took care of her. And after about 17 days of good treatment, when she recovered completely, and the feeling of gratitude she had towards us, well, that is one thing I really remember. And such expressions actually help us do much more and deliver more to our patients.
Amazing. So now let's move to the second phase of our podcast, where I want to go inside an operation theater with you. That is something I feel like a lot of people out there, they don't know what happens inside.
Absolutely.
And I don't know, like, it will be lovely to get it from you, right? So just walk me through what happens when a patient enters the OT.
Before the patient enters the OT, there's a lot more that has to happen so that patient can actually enter the OT.
Yeah.
Let's not talk about, I'll just talk about elective cases. Let's not talk about emergency. Emergency mein to even our thoughts are on high, patient ke thoughts are overwhelmed and all that. So we'll just talk about elective cases. In elective cases, whenever a person thinks of getting a surgery done, the minute that person meets a surgeon in OPD and the surgeon tells that you need to have a surgery for management of this disease, there starts the whole thing. From that moment till the time patient actually enters the operation theater for his surgery, a lot happens. And that is known as pre-anesthetic management of that patient or pre-surgery management of that patient. So in pre-operative phase, we actually go through patient's history, we go through all his investigation, we stratify the risk of that person of going for surgery, and we talk to that person and explain it to them, not only to the patient, or also to the attendants, okay, what all can happen during the surgery. And after all this is done, then we take consents. A surgical consent is there. Then there is an anesthetic consent. Surgeon will explain his part. We will explain our part as an anesthetist, what all can happen and what anesthesia. I will actually be discussing the plan of anesthesia for that patient and how pain management will be done after the surgery is done. All this is done. Then comes that patient. Then comes that day when patient comes to OT. So before we take up the patient in OT, we have a set protocol. Patient being wheeled from room to pre-operative ward, checklist is there to run between the nurses of the two places. Then there's another checklist we run. There is something known as WHO safety check, surgical safety checklist. If you are interested, I can tell you this was basically devised by WHO, and world over, this safety checklist is being followed. And it is a universal safety checklist where we actually keep on asking the patient their identity, what surgery has to be done, which part of the surgery has to be operated, and is there site marking there, and are we actually prepared, not only knowledge wise but infrastructure wise and equipment wise, to go ahead with that surgery. All that is done, then only patient is wheeled into OT, and we check their consents before patient wheeling in the patient to OT. Once a patient is on OT table, the first thing as anesthetists we do is we reassure the patient that everything is going to be perfectly okay. Because it's always better to have a calm patient. We need to have a patient who is calm. We also give them pre-medication in form of anxiolytics so that they are not apprehensive or anxious about their surgery. On table, we put monitors, and there's a whole team working for that patient. It is not only anesthetists. I have technicians working, I have nurses working there, and there are at least 5 to 7 people in OT to take care of that patient before the surgery starts. And once monitors are put, then we go for induction. We induce the patient. Anesthesia is given. Then comes the positioning part. Again, there are multiple people taking care of positioning so that during surgery we do not harm patient. कहीं पर pressure source ना बन जाए, कोई nerve compression ना हो जाए because of positioning. After that, the surgery starts. Once the surgery is done, then we bring back the patient. And it is during the surgery, जो लोगों का myth है ना कि एनेस्थेटिस्ट बेहोश करके चला गया, सर्जन अब ऑपरेट करेगा, फिर जब होश में लाने का टाइम आएगा तो आएगा कर देगा. इट्स नॉट दैट. एनेस्थेटिस्ट इज ऑलवेज सिटिंग नेक्स्ट टू द पेशेंट, monitoring his blood pressure, his SpO2, heart rate, and everything that is possible, urine output. And we maintain the physiology of that patient during anesthesia. And once a surgery is done, then we wake up the patient. And patient usually get up on table, but they are little sleepy. So we monitor them in post-operative ward for about an hour, and then we shift them back to room. That is how. This is a journey of patient who enters a hospital with something to be repaired or something to be managed to the time that management has actually been done.
So, the WHO guidelines that you were talking about, do you think all hospitals in India are following that? Do you think all of them do it?
It is mandatory.
But
it is
do you think they
mandatory.
do it?
All big hospitals, because as per NABH guidelines and JCI, it is mandatory to follow that. These guidelines actually came up by a surgeon in US, Indian surgeon who was practicing in US, Atul Gawande. He has written books like Being Mortal, Checklist, and these guidelines were picked up from one of his book, Checklist. And the main inspiration of making these checklists and these guidelines comes from our airline industry, because the amount of checklist airline industry has, that has inspired medical profession hugely. And we follow all those checklists in OT. Before starting in our OT, हमारा anesthesia machine का checklist is like a cockpit का checklist. And that is the reason a surgical journey of a patient or anesthesia is like hours and hours of, when you must have seen the main issues happen in airline industries during takeoff or landing, not in air. So ours is also the same. Any problem that can happen is during induction of anesthesia or while reversing the anesthesia. In between, patient is monitored at auto mode with our monitors, and patient is taken care of. So that is the reason they say anesthesia is like our airline industry, hours and hours of boredom and moments of terror. So that is what anesthesia is.
And are there different types of anesthesias as well?
Absolutely. There are many types of anesthesia. So broadly classifying anesthesia, there is a general anesthesia where we put our patient to complete unconsciousness. Patient will not have any reflexes, areflexia, no pain, muscles are relaxed, and all body vitals are taken care by anesthetist. Then comes regional anesthesia. In regional anesthesia, we have like spinal anesthesia, epidural anesthesia. We anesthetize the lower part of the body. In regional anesthesia also come nerve blocks. Now we have come to an era where we anesthetize the part of the body where the surgery has to be performed. Suppose somebody has to get a surgery done on one upper limb. So we'll anesthetize that one upper limb only by blocking the nerves which are supplying to that upper limb. And once we block that nerve, there is no sensation for at least 7 to 8 hours till the time effect of local anesthetics is there. And this is known as nerve block form of. And last but not the least is monitored anesthesia care, in which we just sedate the patient little bit to do procedures which can be done under sedation. We don't give them a deep anesthesia. We just sedate them so that our surgeon can perform minor procedures.
So how do you decide कि किस patient को कौन सा anesthesia दे?
How do we decide? There are multiple factors how we decide. It is number one, if I know the surgery has to be done on the lower part of the body, I will talk to the person that I will be giving you spinal anesthesia. That is safe for you. Will not be putting you to sleep completely. We might sedate you so that your anxiety is taken care of. And we'll anesthetize the lower part by giving spinal or epidural. And if some upper limb or any part of the body which has to be operated, and I can give a nerve block and anesthetize that part of the body, then I'll explain to the patient. That is one decision I take. And the major factor that helps us to take decision is patient also. I need to have consent from the patient. अगर मेरा पेशेंट कहता है कि डॉक्टर साहब, आई एम नॉट कंफर्टेबल गेटिंग स्पाइनल, आई वांट टू बी अंडर कंप्लीट एनेस्थीसिया, जनरल एनेस्थीसिया, and if I am convinced that general anesthesia is safe for that patient, then probably I'll give general anesthesia. So there are multiple things which help us to take that decision.
What do you think is your one biggest responsibility inside the operating theatre?
As an anesthetist,
Yes.
my patient's safety.
So you are
Nothing
the
beyond
one
that.
who is totally मतलब पीछे से director and producer, like you said.
Absolutely. I'm focused.
Yeah.
And in fact, I believe all anesthetists will be focused on only one thing, that their patient should be safe during anesthesia and while the surgery is going on.
Patient should be asleep.
Not asleep. Again, it's not putting anybody to asleep. Sulane ko to sulaye. One thing I want to tell you, anesthesia is not a state of deep sleep. That is a myth. People think it's sulana hai. Anesthesia is a state where patient's mind is also completely shut down.
Okay.
To a large extent, patient ke muscles are relaxed, patient ke reflexes are upturned, patient ka pain sensation, brain ka perception of pain is taken care of. But it is not only going to deep sleep, because somebody is arousable from deep sleep. From anesthesia, people are not arousable till the time we want them to come out of anesthesia. It is a very calibrated form of putting somebody to unconsciousness where all vital organs are preserved.
Wonderful. And have you ever had a case where everything changed all of a sudden within seconds?
Many
And
times.
what did that teach you?
many times, as I told you, hours and hours of boredom and moments of terror. So moments of terror would come in everybody's life while the surgery is on. You're going through a simple elective surgery, and there is an arterial bleed or a venous bleed or unexpectedly bleeding, and patient's BP starts falling down. That is a moment of terror I'm talking about. There comes our role, how to manage that so that we maintain vitals to normal value. We we not only give them more fluids, we arrange blood for them, we transfuse blood to them, and we help our surgeon to take care of that bleeding by keeping our patient more relaxed and by maintaining the vitals of that person. So these moments of terror will be there, and more so in surgical field and more so with anesthesia.
Okay. What do you think are some points that people should know and should discuss with their anesthesiologists before the surgery?
I personally believe that every patient who is planning a surgery should have a pre-anesthetic checkup, that is PAC, with an anesthetist. And there, the anesthetist will get to know about the patient, the investigations of the patient and the history of patient. And patient also gets chance to talk to the anesthetist and fulfill all his or her queries. And the main queries every person should ask anesthetist, because end of the day they are going to surrender themselves for their body to be cut under anesthesia, and it is their right to know what form of anesthesia will be given to them, for how long anesthesia will be given to them, when will they come to when will they come to recovery, and for how long they will be feeling that sleepy feeling, how the pain will be managed post operatively, will they be shifted to ICU or room, and last but not the least, when will they be street fit to go ahead with their normal life after an anesthetic episode, and when they will be discharged. So these are the basic things every individual needs to ask their anesthetist and satisfy themselves before they consent for an anesthesia and surgery.
Wonderful. Once again, coming back to the misconceptions about anesthesia, what are some of the myths about anesthesia that do not disappear?
The biggest myth is, क्या मैं जागूंगा या नहीं जागूंगा? ठीक है, मेरे को होश आएगा ना डॉक्टर साहब? दे पीपल एक्चुअली अबाउट 80% ऑफ देम वुड बी आस्किंग अस, डॉक्टर साहब होश आ जाएगा ना पक्का? मैं क्या, तो हम भी मजाक में कई बार बोलते हैं, आज तक तो ऐसा कोई हुआ नहीं कि जो बेहोश ही रह गया हो, या हमेशा आता है, तो आपका भी आएगा. वही एज आई ऑलरेडी सेड कि हम हमेशा ये कहते हैं, आवर मेन ट्रेनिंग इज नॉट टू पुट यू टू स्लीप बट टू ब्रिंग यू बैक टू लाइफ. एंड सेकेंड मिसकंसेप्शन इज, कहीं मैं बीच में तो नहीं जाग जाऊंगा. अवेयरनेस, that can happen, though it is very rare in today's era, because our monitoring is so good and precise that we know what's happening in their body, how aware how deep the brain is sleeping. We actually are monitoring that. We have bispectral indexes, best जिसको बोलते हैं, which we know कि depth of anesthesia कितना है. We actually monitor that for every patient. So that is a second apprehension people will have. And third apprehension people will have, especially about regional anesthesia, spinal लगाते हैं. डॉक्टर साहब एक बार इंजेक्शन बैक कमर में लग जाएगा तो पूरी उम्र दर्द रहेगी. And it is one of the biggest myth people have. And I tell them, my pet statement to them is, कमर में दर्द होगा या नहीं होगा उसकी गारंटी नहीं है, पर इसकी गारंटी है कि इस इंजेक्शन की वजह से नहीं होगा. It is actually a myth, because they keep on hearing from people who have had spinal anesthesia, and I tell them कि दर्दें तो सबको लगी रहती हैं, दर्द तो उसको भी कमर में होता है जिसको कभी कोई इंजेक्शन मिला भी नहीं, वो किसको ब्लेम करेगा. So these are the few myths people have, and we as anesthetists, I think the best way is to talk to them and explain everything to them. The more we explain to them, the better their ideas will be. And not only that, once they've gone through all that, We want our patients only to be the brand ambassador to remove these myths from society. And that can happen only if we deliver that best to them.
Nausea and drowsiness and sleepiness, is that all common with anesthesia?
Today, it is relatively not so common. The incidence has gone down, but there was a time when I think practically 80% of anesthetic event was associated with post-operative nausea and vomiting. बिकॉज हमारे ड्रग्स उस टाइम पे ऐसे थे जिनसे नोजिया एक्चुअली ब्रेन को स्टिमुलेट करता था नोजिया करने के लिए, एनेस्थेटिक ड्रग्स. बट टुडे एनेस्थीसिया हैज बिकम सो सेफ, सो कंफर्टेबल, and incidence of nausea and vomiting has gone down. Our medicines are far superior, which will not produce that nausea and vomiting. Plus, our understanding has become so good that preemptively we manage our patients so that they don't have that nausea and vomiting. Drowsiness, yes, every anesthetic event will have drowsiness. There was an era कि किसी को जनरल एनेस्थीसिया दिया जाता तो वो अगले दिन उठता था, जिसको उठना बोलते हैं कि अब मेरे को होश आया टाइप्स. But today our patients are awake, on table, and within couple of hours they are wide awake, talking, and by evening we discharge them after a proper general anesthesia. So things have changed. Safety has become lot more, much better for patients. Anesthetic drugs are far superior, much more smoother, with least complications.
Wonderful. And what do you think has changed? Matlab, before जो anesthesia का style था, let's say in the past 2 decades, right? Versus now. Is it the medicines? Is it the machines? What is it?
Before I comment on this, I would like to tell you not much improvement has happened in form of surgical steps. Surgical steps वही हैं because anatomy वही है. So in surgical field, yes, technology has come in, laparoscopy, robotics, and all that, which has decreased the incidence of post-operative pain and all. But lot has happened in anesthesia in last 2 decades. And the biggest that has happened is our workstations. Today we have monitors. Our monitoring has become so precise. In fact, artificial intelligence has come into play, and our monitoring is so precise that it can predict a mishap going to happen before it actually happens, and warns us, alerts us that we can take a step so that mishap does not happen. Our monitors are such will predict कि इस patient को BP कम होने वाला है in next 2 minutes or 4 minutes or 5 minutes. So that preemptively we take measures to maintain that blood pressure. So technology has come up by leaps and bounds. It is supporting us. Artificial intelligence is supporting us big way, and our drugs have become so smooth. Our inhalational agents, our IV induction agents have become so good and so smooth. Anesthesia today is a switch on, switch off mechanism. You switch on, they go to sleep. You switch off, they are wide awake. So that is what anesthesia has become today. The safety is a lot more than what it used to be about a couple of decades back.
Okay. Wonderful. And what do you think AI's role in the future is going to be in this field?
AI is going to be a big player in this field. It is going to support an anesthetist. It is going to be a buddy for every anesthetist. AI is going to actually help anesthetist to make his life comfortable and his patient's life more safe. Our life becomes comfortable because of AI playing a role, and our patients are much more safer because of AI is there. But one thing I can assure you, AI is not going to replace an anesthetist, presence of anesthetist and OT. It is just going to support us as a buddy who will tell us, raise alerts that the problem is going to come before the problem actually comes. And that is the reason I believe every anesthetist should be well versed with role of artificial intelligence in healthcare. It is very important. to make themselves more learned, understanding becomes a lot better, and to make their patients more safe. So that
And
is
has it already started playing that role?
yes. In fact, I'll tell you, our workstations today have started integrating anesthesia workstations have started integrating artificial intelligence into them. There are many things which will predict कि इस पेशेंट को हाइपोक्सिया होने वाला है. व्हेन आई से हाइपोक्सिया, इसकी सैचुरेशन कम होगी आगे, डिपेंडिंग ऑन द सर्जिकल स्टेप वो पेशेंट का चल रहा है, या पेशेंट की जो वेंटिलेशन जो चल रही है, जो हम वेंटिलेट करते हैं ड्यूरिंग एनेस्थीसिया, वो पहले प्रिडिक्ट कर लेता है कि इस टाइम पे इसको हाइपोक्सिया होने वाला है, सो दैट वी मेक desirable changes so that that does not happen. So our workstations today, the new ones are with AI integration, which will actually tell us कि हमारे पेशेंट की डेप्थ ऑफ एनेस्थीसिया कितनी है और कितना मेंटेन करना है. So it is big way into healthcare today and helping us to do lot better and have a safe patient.
That is amazing to hear.
Yes, it is.
So, okay, coming back into the operation theater, you work with a lot of doctors, a lot of teams. What do you think makes a high performing operating theater?
The biggest thing that makes a high performing operating theater successful is team effort. It is not one individual. It is a team effort with supporting infrastructure, with excellent world-class equipment. All these play in tandem, in harmony with each other to have a very high-performing OT. A good team with excellent knowledge, good communication, and good understanding with each other, supported by excellent monitors and excellent equipment to perform the surgery, and supported by the infrastructure which is going to take care of sterility, infection control, and all that, delivers the best results. I think it is amalgamation of all these factors which will make one good, modern, out of the world, out of class operating theater, which can deliver maximum.
So, sometimes, do you think there are also, so when there's a team, there's a lot of communication. Do you think sometimes there are also communication failures?
Absolutely.
So,
Absolutely. You heard of Chinese whisper? Chinese whisper hota hai na?
Mhm.
What is Chinese whisper? It's a communication failure. So it is like that only. So that is the reason I believe when a team is working, if our communication in between, when I say team, an anesthetist, a surgeon, a nurses, technician, my GDA who cleans my OT, general duty assistant who cleans my OT, everybody has to be communicated clearly. That communication has to be so clear and crisp and loud that there are no communication gaps. We should be on same page for that patient. So communication plays a major role in preventing disasters.
Okay. And do you think, where do protocols fit in here? Can protocols make a hospital safe, or is it culture that matters more?
Both. Protocols is in fact having a safe culture. That is it. Protocols drive that safe culture. So you have to have protocol. आपने पढ़ा होगा काफी सावधानी घटी दुर्घटना घटी पढ़ा है ना. What protocols do is help you to be savdhan always, because they define a way things should be done, and if there's a breach of protocol at any one given time, you are making your system weak and vulnerable for a disaster. So protocols are must. You must have heard of Swiss cheese model of human errors. It is management program. A Swiss cheese model होता है. इस Swiss cheese model में आपने Swiss cheese देखा, उसके अंदर holes होते हैं. They are triangular bars of cheese with holes in it. And when all the holes of all the blocks coincide with each other, you actually allow porosity and a disaster will happen. So it starts from planning, a good communication, good documentation, understanding of good documentation by everyone, and then delivering. And all this is managed by making good protocols. If you have protocols in place, you will not allow that Swiss cheese model for a disaster to happen. So protocols define us, they define our way of working, and it should be followed. It's basically like governance. You have to have a proper way of governance. You just cannot have a random way of managing things. There has to be a way of managing things.
And where does culture fit in here?
Culture is basically our thought process, what we think about delivering. If you have that empathetic culture towards your patient, towards your profession, if you have that safety oriented culture, and if you have that hard working deliverance type of culture, that along with protocols is going to give you the best results and decrease the disasters or mishaps.
So, you've been involved in quality control, infection control committees as well in the hospitals, right? Where do hospitals struggle the most with patient safety?
I'm medical director of a hospital, so I am into practically every committee of hospital and looking after every parameter which support hospital to deliver good healthcare to our patients. So talking about infection control, first and foremost thing is to have a infrastructure which makes your operation theaters infection safe, so that there is no infection. Then you have to have good teams which will, and your protocols in place, our cleaning protocols, our HEPA filter validation protocols, our air exchanges protocols in operation theater, management of humidity, management of temperature in operation theater. All these things, they have to be managed, and our quality teams look after, they do regular audits, and they look after that the protocols which have been made, are they being actually implemented or not. एक प्रोटोकॉल बनाने से चीज़ें नहीं ठीक हो जाती, उसका इम्प्लीमेंटेशन इज इक्वली इम्पॉर्टेंट, एंड आफ्टर इम्प्लीमेंटेशन ऑडिट करना इज वेरी इंपॉर्टेंट कि वो ठीक से इम्प्लीमेंट हो रहा है या उस इम्प्लीमेंटेशन से कितना बेनिफिट हो रहा है हमको और हम कितना और इम्प्रूव कर सकते हैं. So all these things are, so infection control nurses, infection control officer, along with quality team, along with people who are actually delivering, they are the people who have to understand and follow these protocols. And these quality teams and infection control officers and nurses are the checklist, are the I'll say CCTV cameras on them. Actually, they are doing what they are expected to do as per the protocols.
Patient safety को लेकर के, how can a hospital or a team of doctors ensure that the patient safety is taken care of?
When we talk about surgical safety, तो as I told you कि WHO surgical safety checklist है. Well, just to give you an idea कि how this came into existence, this surgical safety checklist. Dr. Atul Gawande, he is a doctor who is a New York based practicing there. In I think early 90s, this project started. He wrote a book by name of Being Mortal. Then there is another one, Checklist, Manifestation, and all that. So from there came the idea to have a good checklist so that we can keep our patients safe. And as I told you, these checklists are inspired from airline industries. Dr. Atul Gawande की जो checklist थी, उसको 1992 में it was taken up, and वहाँ से एक WHO surgical safety checklist बनी, which then became mandatory as per NABH and JCI for every hospital to implement. And it is so mandatory that one of the parameters of capturing, safety parameters of capturing is whether the implementation of the surgical compliance of the surgical safety checklist is being done or not. So this is how we can make sure that everything which is being done is being done as per protocol and patient safety is taken care of.
Apart from this, one thing that I want to ask you, when you started off as a doctor versus to 25 plus years later now being MD of a hospital, what is the difference in responsibilities or maybe the pressure, anything?
I'll not say responsibility or pressure. As you start working, you learn to take those responsibilities. You will be surprised to know most of the hospitals will have an anesthetist as either the MD or somebody who is taking care of administration. Why? Because OT itself is a small world within the big hospital. It is an enclosed space जहाँ पर सारी दुनिया बसी हुई है. And OT is one place जहाँ पर you make sure that everything goes by the books, by the protocols, and managing these protocols, the in charge of OT automatically end up being an administrator. So it actually, the way you work and what you are expected to deliver and what you are expected to work with makes you an administrator. So I think it was my working was my learning, and that helped me to become an MD.
And when new students practicing medicine, they start out, what is one common mistake that they make? Or some advice for the new upcoming and young doctors?
My biggest advice to anyone is have an attitude to work. बाकी सब चीज़ें आ जाती हैं. सीखने के लिए, कुछ पाने के लिए आपको एक एटीट्यूड होना ज़रूरी है, विनम्र होना ज़रूरी है. तब ऑटोमेटिकली यू विल लर्न. मैं किसी को सिलेक्शन भी अगर करता हूँ, मैं ये नहीं देखता कि उसको कितना आता है, कितने प्रोसीजर्स कर सकता है, कितना ज़्यादा कर सकता है. मैं ये देखता हूँ क्या उसमें एक एटीट्यूड है नया सीखने का, कुछ और करने का. बिकॉज जिसके पास वो एटीट्यूड टू एक्वायर मोर नॉलेज, वो भूख टू लर्न मोर, डू बेटर. एंड दूसरा इज हाउ एम्पैथेटिक दैट पर्सन इज टूवर्ड्स others. Our EQ is very important. Emotional quotient is very important. मुन्ना भाई MBBS में बोला था कि मैं यहाँ पर किसी के साथ इमोशनली अटैच होने नहीं आया, ये बोला था ना. बट एंड ऑफ द मूवी में दे एक्चुअली प्रूव्ड इट दैट योर इमोशनल क्वोशंट इज वेरी इंपॉर्टेंट. यू हैव टू बी कनेक्टेड टू योर पेशेंट हु हैव entrusted everything on you. तो मेरा यही है, एज अ सीनियर एंड एज अ पर्सन हु इज इनटू एडमिनिस्ट्रेशन, आई वुड एडवाइज एनीवन के बी एम्पैथेटिक towards your profession, towards your patients, and be dedicated towards your profession. That's it.
If you were given complete control over improving one aspect of hospital safety across India, what would you focus on first?
I think I will focus more on delivering healthcare at a reasonable price with us and making healthcare available to everyone. What is happening is we have two parallel systems running in our country. I believe both the systems, they focus on safety of patient, but one system is so overworked and overloaded that they are unable to, plus they don't have that type of support from government to take care of patient safety the way it should be taken care of. On the other side, we have a private system which does talk about taking care of patient safety, which does invest into patient safety and does take care of patient safety, but it is accessible to very small population. So I believe that we have to merge these two systems and come to a midway where we can deliver patient safety and more accessible to everyone. That is what I believe. Okay, why should somebody who is going to government hospital not taken care of the way person who is can afford and goes to a private hospital is taken care of? That is what I believe. अगर मेरे को बोला जाएगा तो मैं इन दोनों को मर्ज करने के लिए करूंगा, एफर्ट डालूंगा, गवर्नमेंट की पूरी सपोर्ट मांगूंगा इन चीज़ों को करने के लिए, ताकि वी कैन डिलीवर अ सेफ and excellent healthcare to each and every citizen of this country at an affordable price.
So we talked about AI. We talked about how it is already an emerging trend, already a buddy in the OT. Are there any other sort of healthcare technologies that excite you?
I think AI is the latest. That's my passion as of today. So I don't think AI is into everything. Any technology you pick, be it robotics, be it laparoscopy, be it anything, be it anesthesia, be it radiology, and be it any modality of investigations, AI is playing a big role. तो I think AI से बड़ी चीज़ आजकल तो नहीं है, और हर किसी को वही intriguing लगता है, and I think everybody is thinking of learning more and more about AI so that they can actually move along with the changing trends in this world. Not only in healthcare, in every profession. It is in every profession. वो कहते हैं ना, people will not be replaced by AI. People without AI knowledge will be replaced by people with AI knowledge. So that is what is more important today. And that is the message for all of us, including me sitting here. If I have to move on in this profession, I will have to upgrade myself. And everyone should upgrade themselves with the latest that is happening, and that is artificial intelligence.
So, in the world full of emerging technologies, right, like AI, there is a big gap, like we talked, in a country like India, where somewhere in a private setting, in a private hospital, we have AI and we have cutting edge technology, versus on the government end, there are still a lot of questions around safety and proper treatment. What do you think India should prioritize to improve this situation over the next 10 years? What is the one place where maximum focus should be given?
One place where maximum focus should be given in healthcare is primary healthcare. When I say primary healthcare, I mean how we can avoid diseases. Awareness, knowledge is very important. ताकि बीमारी होने से पहले ही उसको अगर हम प्रिवेंट कर ले, अपने आप को कैसे हेल्दी रखना है, वो होना बहुत ज़रूरी है. Today, because of lifestyle modification, because of our lifestyle, we have lifestyle diseases. Diabetes is on the rise. India is world's second highest incidence of diabetes. Diabetes is on the rise, hypertension is on the rise, obesity is there. So I believe that primary health care, where awareness is given and people are taught and people are made aware that you can, if you manage your lifestyle and modify your lifestyle, you can actually save yourself from going to a hospital. हमारा फोकस सारा, स्पेशली प्राइवेट सेटअप में, फोकस टर्शरी हेल्थ केयर पे है. हॉस्पिटल्स को कैसे बड़ा सा बड़ा बनाया जाए, और मनी शुड बी पुट अप so that we have the latest technology, but we are not focusing how we can actually avoid these diseases. उस पे फोकस होना बहुत ज़रूरी है. To have a healthy society, that is very important. तो हमारा मेन फोकस उस पे होना चाहिए.
So instead of focusing on treatment, prevention is
always better. Let's prevent. हमारे same is true in, हमने कार इंडस्ट्री में 6 एयरबैग्स, सेफ्टी मॉड्यूल जितने ज़्यादा गाड़ियों में लगा दिए, बट उससे ज़्यादा इम्पॉर्टेंट है टू हैव बेटर रोड्स, मोर नॉलेज एंड फॉलोइंग ऑफ ट्रैफिक रूल्स. That is everywhere in every profession. Prevention is always better than
Sure.
those safety products we are talking about. वो भी है, वो अपनी जगह होने चाहिए. But why have an accident? Why be sick and go to hospital? And how we can prevent that? That is more important.
And inside the hospital, when we talk about HAIs, right? I was reading somewhere that 1 in 10 people catch HAI when they go to a hospital for treatment.
Yeah, it is possible. It is.
So, what can be done about that?
Many things are being taken care of to bring these HAIs. Why people are vulnerable to hospital-acquired infections? One of the commonest things is anybody who comes to hospital is already immunocompromised and entering in a area which is full of infections. An immunocompromised person entering in an area which is full of infection, so they are more vulnerable and they are more prone to infections. What we need to do is we have to have our sterility in place. We have to have our infection control manuals in place so that minimum infection. That is the reason we have infection control manuals and infection control protocols in every hospital so that we can bring down these HAIs. And last is minimum hospitalization. We need to encourage people that hospitals will make you okay so that you can go home and recover, not stay in hospital to recover. So minimum hospitalization, go out of that environment, which makes you more vulnerable and prone to infections as early as possible. So that is what is required. With all safety, infection control processes in place.
So, on the same topic, how big of a role this prevention, infection prevention, and operational discipline play in the patient's outcome?
It plays a major role, not only in patient outcome, also in economic burden on healthcare. If all these protocols are followed and hospital-acquired infections are kept to minimum, your patient recovery is faster, your patient will be healthier faster. One surgical site infection actually increases length of stay by 3 to 5 days. That is an economic burden on the hospital as well as on the patient who is paying from his own pocket. One surgical site infection actually is such a big economic burden that uska antibiotic usage goes up. So we have to make sure that our infection control processes are so stringent and robust that our patients walk out of hospital without infection or as early as possible. Because it is going, and this economic burden is not only on the hospital, this economic burden is on whole of healthcare per se. This economic burden is on the nation's economy also, because insurances come into play. Well, everything is linked. किसी एक पेशेंट का 2 दिन का स्टे अगर ज्यादा होता है, उसकी इंश्योरेंस कंपनी को वो 2 दिन का स्टे ज्यादा देना पड़ता है. उस इंश्योरेंस कंपनी को जिससे ज्यादा देना पड़ेगा वो आपके प्रीमियम्स बढ़ाएगा. It's a vicious cycle. You're getting my point? So to break that vicious cycle, we have to make our healthcare system so robust that we don't have these hospital-acquired infections, which will be economic burden on the nation itself.
On the same topic, why do you think healthcare is becoming more expensive day by day?
I think just because we have to have all these protocols in place, healthcare will be expensive. It is going to be expensive if you want to make sure that your patients don't have infection in hospital or get the best. Because of technology which has been, there is a lot of expense which is involved backhand to deliver the best to our patients. And because of all this, healthcare is bound to be more expensive. The technology, the deliverance, hospital infection control protocols, implementing hospital infection control protocols, everything is going to make things expensive. And that is the reason healthcare is actually becoming more expensive.
If hospitals could eliminate one preventable risk over the next decade, what would you choose?
Infections. Seriously. Especially in tropical countries like ours. And especially surgical infections, surgical site infections. I think these should be eliminated to have a more efficient system of healthcare deliverance. Infections ko humko eliminate karna padega. And I think lot is being done on this side, and lot is being invested on this side to have minimum infection rate, especially to patients who come for treatment to hospitals.
Any question, any area that you want to explore?
So, you talked about why expenses are going up. I said just to have a healthier environment where recovery is faster and patients are more healthy, we have to have an infrastructure which can deliver all that. Just to give you a small example, today a modular OT, operation theatre, is equipped with HEPA filters, with a laminar flow, with air exchanges happening, with a separate AHU, air handling unit, where humidity, temperature, and everything is taken care of, is managed properly. All these infrastructure requires an expense. And because of all this, healthcare is becoming expensive to deliver the best to our patients. आज से 20 साल पहले नर्सिंग होम से वो भी ऑपरेशन थिएटर्स होते थे. घर के अंदर एक कमरे को ऑपरेशन थिएटर का लेबल लगा दिया जाता था, एक एयर कंडीशनर लगा दिया जाता था, उस पे 4 स्लैब पे 4 ड्रम्स रखे जाते थे स्टेराइल इक्विपमेंट इंस्ट्रूमेंट्स के, उसी में से निकाल के आप एक टेबल डाल दिया, एक ओटी लाइट बना दी, हमारा ऑपरेशन थिएटर बन गया. गॉन इज दैट एरा. आज एरा ऐसा आ गया जहां पर वी आर डूइंग लॉट मोर कॉम्प्लिकेटेड प्रोसीजर्स एंड सर्जरीज, जहां पर हमारे सिस्टम को और रोबस्ट होना पड़ेगा और फुल प्रूफ होना पड़ेगा. उसके लिए लॉट इज बीइंग डन, एंड ऑल दिस लीड्स टू एन एडेड एक्सपेंस टू हेल्थ केयर.
Do you have some story about HAIs that you would like to share?
मेरा एक स्पाइन सर्जरी का पेशेंट था. उस स्पाइन सर्जरी के पेशेंट की हमने लंबा स्पाइन फिक्सेशन कराई, and after that, young boy of 22 years old, he came with simple disc prolapse with disc alignment, vertebral disalignment. तो उसके लिए हमने उसकी स्पाइन फिक्सेशन विद डिसेक्टमी वगैरह कराई थी. Unfortunately, that patient had a surgical site infection, whatever the reason is. वो patient stayed with us for about 3 weeks, more than 3 weeks. उसका सिर्फ burden ही नहीं, that patient lost about 15 kgs in a month's time.
15 kgs.
15 kgs. मैं उस लड़के का आज भी उसका चेहरा मेरे आगे आता है कि what one hospital acquired infection or surgical site infection can do to a young healthy adult who comes for an elective surgery. पैसा तो जो लगा, I think family must have paid through their nose. So that is the reason these things are very important.
Okay, let's finish on a lighter note. Let's go to rapid fire. Ready? Coffee or tea?
Coffee.
One medical myth you'd eliminate forever.
कि डॉक्टर सब कुछ ठीक कर सकता है.
One habit everyone should adopt for better health.
Walking.
One book that influenced your thinking.
Fountainhead by Ayn Rand.
Okay.
I know it's not a medical book, but that played a major role in me being what I am today.
Wonderful. The best advice you've ever received.
Everything is possible. Manifest it.
A patient interaction you'll never forget.
My dad was with me, and my dad had come to visit me in my previous hospital. And there was this patient who I anesthetized, and during her surgery, I was very compassionate towards her. And this patient never knew that my dad is standing next to me. She just came and hugged me. Old lady. She just came and hugged me and thanked me. आई थिंक दैट इंटरेक्शन मेरे डैडी भी मैं याद करते थे, बेटे कितनी अच्छी बात है ना, पेशेंट्स ऐसे याद रखते हैं, वो भी एक एनेस्थेटिस्ट को. सो आई कैन नॉट फॉरगेट दैट.
If you weren't a doctor, what would you be?
एमसीडी का कर्मचारी होता, क्योंकि सफाई फ्रीक हूँ. आई एम क्लीनलीनेस फ्रीक. सो आई वुड हैव बीन इन एमसीडी एंड आई वुड हैव मेड श्योर कि दिल्ली की सारी चीज़ें साफ हो जाए, क्लीनलीनेस मेंटेन हो जाए. दिल से कह रहा हूँ. या फिजिक्स का प्रोफेसर होता. फिजिक्स वाज माय सेकंड लव.
Okay. What does success mean to you today?
Being happy and contented. Seriously. Money can never give you success. Contentment can give you success. Being healthy, happy, and contented. These three things are very important to me today. और जैसे जैसे उम्र बढ़ रही है, इनकी वैल्यू और ज़्यादा पता लगती है.
Great. That's a wrap. Thank you so much. Thank you.
I would like to congratulate you for having such a good session. Well, even I enjoyed being with you. And good luck to you.
All thanks to you, sir. Conversations like these remind us that healthcare isn't about treatment. It's about trust, teamwork, and people who dedicate their lives to keeping us safe. And thank you, everyone who joined us today. If this conversation gave you a new perspective, don't forget to follow, share it with someone who would find it valuable, and stay tuned for more conversations that go beyond the surface. Until next time, I'm Mansimran Singh. Take care.